Good morning and welcome to the next talk in our morning on respiratory infections, that is bronchiectasis and pneumonia, clinical, radiographic, and microbiologic features. I have no conflicts to disclose. I will mention some off-label utilizations in my talk. So the structure of my talk is really in 3 sections, and there are separate learning goals for each section. They are bronchiectasis, NTM, or non-tuberculous mycobacterial infections, and pneumonia. Each section has some embedded patient cases in it. From the topic, you'll see it's impossible to do a comprehensive update in one talk. So what I'm going to do is 2 things. The first is to emphasize the touch points where infectious disease clinicians are involved. And the second is really to focus on some specific areas, and that is integrating nuanced features of clinical presentation, radiology, microbiology that aid in the prevention, diagnosis, and management of these 3 conditions. And what I'm hoping to do is give you a talk where you can't read this information in a book. It's really gathered from many different sources. So here are the learning goals for bronchiectasis: to recognize the key features and the underlying conditions that are associated with bronchiectasis, to review the current state of bronchiectasis management as it relates both to infectious diseases, but the other common associated conditions we see, and to appreciate the state of the evidence supporting the guidelines for management of bronchiectasis, which I'll cite here. I'm going to use a couple of patient examples to introduce the topic. And these are both patients I've seen in the past. This is a recent patient who's a 78-year-old woman, and her history is that she's a nurse, and she converted her tuberculin skin test in the 1960s when she was working abroad. She's never been treated for latent TB. Since 2018, she's developed a chronic progressive cough with some sputum production and is treated with 2 to 3 courses of antibiotics a year. She has a CT scan, which you can see here, and what this shows is some bronchial thickening, some bronchiolar thickening, some peribronchial inflammation, and also some esophageal dilation, and what you don't see here is a hiatal hernia. She's diagnosed with reflux and silent aspiration and put on omeprazole and a low-acid diet. However, her symptoms worsen, and she has 2 episodes of pneumonia. Her second episode is when you're seeing her, and the CAT scan here shows obstruction of the superior segment of the right lower lobe, with central lobular here, you see these tree and bud opacities, but also distal consolidation. She undergoes bronchoscopy, which shows inflammation in the airways, copious secretions in this segment, no endobronchial lesions, and the culture grows MRSA and Pseudomonas. Here's another patient who's a 32-year-old male with an acute onset of fevers, productive cough, and shortness of breath. He gives a 10-year history of progressive cough with 1 episode of pneumonia and 2 to 3 yearly episodes called bronchitis and treated with outpatient antibiotics. Of note, he was born in Haiti and immigrated to the US 10 years prior to admission. He has no childhood vaccines that he received, and he reports many childhood respiratory infections. The chest x-ray on the top is his admission chest x-ray, and the person who initially saw this chest x-ray read it as streaky lower lobe opacities with patchy left lower lobe consolidation. I think that reflects the fact that many of us in the US don't see a lot of bronchiectasis, and we're not attuned to the features on chest x-ray. In fact, the CT showed marked dilated airways in the lower lobe, this picture of saccular bronchiectasis. He was PPD negative and subsequent sputums were negative. So what is bronchiectasis? It's really a clinical syndrome characterized by airways destruction caused by inflammation and infection. The reported prevalence and incidence are increasing, although it's not a reportable disease, and female predominance is the rule both here and in Europe. It features chronic cough, eventually with viscid sputum, permanently thickened and dilated bronchi, and recurrent symptomatic respiratory tract infections. Unfortunately, the etiology in most cases is unknown, and there are no good animal models. Let's talk a little bit about the terminology in bronchiectasis. Here is a slide, and you'll see on the right-hand side the term cylindrical bronchiectasis, otherwise known as tram track appearance, to resemble a train track. And you'll see here a bronchus that has a thickened wall and it's only mildly dilated. As bronchiectasis progresses, it is called varicose bronchiectasis. And here you see an example of that. Another term for that is string of beads because of the resemblance. And then finally, late-stage bronchiectasis is called cystic. And you can see that's also called a cluster of grapes, where there's destruction of large areas of lungs. Another term that you'll see is the signet ring sign, and this means peribronchial inflammation or peribronchial nodules. So you'll see tree and bud opacities in many X-ray and CT reports in bronchiectasis. And what exactly does that mean? Well, on the left, you'll see a schematic of normal bronchial anatomy. And in the blue, you'll see cartilage. And as you notice, about halfway between the trachea at the top and the periphery here at the bottom with the alveolar sacs, the amount of cartilage is decreased to the point where it shouldn't be visible on a CT scan. So if you see small airways beyond about halfway between the trachea and the periphery, it means they're thickened or enlarged. And on the right is a CT scan that shows both bronchial thickening and dilation, but also thickening and dilation of small airways. Someone, once upon a time, thought that this resembled a tree in the spring with buds that are about to erupt, and this term caught on. If the airways are inflamed or mucus impacted, we call that bronchiolitis. But if they're actually dilated, as with some of these, that's called bronchiolectasis. Not a commonly used term, but apt. So tree and bud opacities reflect inflammatory obstruction of small airways. And the original description was related to endobronchial spread of TB, often from a cavity down into the bronchial tree. But please remember, even though the radiologist might say, consider a mycobacterial disease, this is not just mycobacteria. Infections include viruses, mycoplasma, and fungi, aspiration, as we saw in our first patient, neoplasia, which we'll review, and other forms of airways inflammation. Unfortunately, most cases are idiopathic. So here's a schema of the proposed pathogenesis of bronchiectasis. It's called the Cole's vicious cycle hypothesis. And what's important to note here is that people can enter this cycle at various points. And in some cases, you do know that they have a condition associated with one of these points, but other times they don't. And these are events that happen essentially in everyone with advanced bronchiectasis. So over here, impaired mucociliary clearance and innate and adaptive immune defects, which may contribute, colonization with microorganisms that contribute to bronchiectasis, not only neutrophil-mediated, but in some conditions, eosinophil-mediated inflammation. And all of this leads to chronic infection, but also periods of exacerbations of infection. Over time, there's loss of cilia and mucociliary function and destruction of the bronchial wall, and that leads to more mucus retention and lung injury and inspissation of mucus. So why do we evaluate for associated conditions in bronchiectasis, since we've said they're present in the minority of cases? Well, the first is patients want to know. But also in cohort studies, 15 to 30% of patients received a diagnosis that altered the prevention or treatment of their bronchiectasis. That could be treatment of an infection, treatment of an autoimmune disease, treatment of immunodeficiency, and very commonly, as in our first patient, treatment of GERD. Rarely, but important for the patient and family, is genetic counseling and testing. So here are some associations. At the top are the more common ones and some of the diagnostic testing. Idiopathic is a diagnosis of exclusion. Up to 30% of people with COPD have some degree of bronchiectasis on imaging, but it's usually relatively mild. And as you know, there's several staging systems for COPD. GERD and aspiration often results in more focal bronchiectasis. Remember, can depend on the position you're lying in. And sometimes a GI evaluation is required. In someone with a suggestive history and a hiatal hernia or a patulous fluid-filled esophagus, it may not be necessary. Infections can cause bronchiectasis, including TB and viral infections, and everyone should have TB testing. And then other infections such as non-tuberculous mycobacteria are also associated. And there are both clinical phenotypes we'll discuss and sputum studies here. I'll let you read through the list of the additional associations. So there are management guidelines for bronchiectasis, but evidence here is often weak or conditional. And it's really important to remember that, like many clinical practice guidelines, not only are there no randomized studies, but in addition, there isn't validation of these guidelines with testing before or after implementation. So it's important to consider them a place to start rather than a validated guideline. Here are some of the things we think about in management of bronchiectasis, and I'm going to walk through the top row here first. A CT in everyone with a suggestive history or a radiograph, and then basic laboratory evaluation. We treat the underlying cause in the patients in whom it's present. And in addition to these features, I'm going to talk more about GERD. We also initiate airway clearance modalities, which may simply be exercise, which is good at airway clearance, but for others, a nebulized agent, chest PT, device-associated airways clearance, or rarely postural positioning. Although we as clinicians think that this helps, be aware there's very limited data about airway clearance. Finally, we'll talk more about macrolide therapy. I do want to mention that in addition to macrolides, which target inflammation, there are agents in study that are specifically targeted to neutrophilic or eosinophilic inflammation in patients with bronchiectasis. If you continue here, you'll see that sputum culture should be obtained in everyone. And what you do with that information depends on the clinical and radiographic features of the patient. If they're having either chronic or acute flares of symptoms, we target the specific bacteria that are isolated from sputums. If they have Pseudomonas in their airways and it's the first time it's noted, we attempt eradication with a course of treatment. This succeeds the minority of the time. And if it's chronic and they're having symptoms, we use inhaled antibiotics as suppression. Please note there's no role for inhaled antibiotics in acute flares. And we're certainly going to talk more about non-tuberculous mycobacteria. So moving on to GERD, GI reflux is often a chronic disease, even if the symptoms are episodic. In our patient that I presented, patient 1, unfortunately, she stopped all precautions for years after her symptoms improved. And that may have led to an unnecessary exacerbation of her bronchiectasis. Treatment for GERD includes not only pharmacotherapy with proton pump inhibitors, but chronic behavioral and dietary precautions. And here's a handout, and I unfortunately can't remember the source of this, so I can't attribute it. But it goes through some important things that I give to patients, which is eat smaller meals, don't eat or drink 2 to 3 hours before lying down, and elevation of the head of your bed, not with pillows or wedges, but by putting a 4 or 6-inch wooden block under the head of your bed, under the legs, to create a gentle grade. What about oral macrolides? Well, the benefits are that there are actually 3 multicenter randomized trials and 1 meta-analysis of azithromycin. It decreases cough and other symptoms, decreases exacerbations, and both in the CF and non-CF setting, there is a decrease, at least in the short term, in incident NTM infections. The risk much feared by ID doctors is an increase in macrolide-resistant respiratory bacteria. And you can show, for example, that patients who take it, their pneumococcus becomes less susceptible to azithromycin. But interestingly, even in those patients, the clinical benefit persists. There's also a risk of increase in colonization with Pseudomonas and other non-enteric gram-negatives, and a potential for macrolide-resistant NTM. So anyone who's grown one in the sputum should not have macrolide therapy. So you notice that algorithm I showed you for management doesn't include vaccination, and that was shocking to me, and it should be in all bronchiectasis management algorithms. First, there's a clear association between vaccine-preventable childhood viral infections and bronchiectasis, and those may have contributed in patient 2 with severe bronchiectasis. But also many pathogens found in the sputum in bronchiectasis flares or bronchiectasis-associated pneumonia are vaccine preventable. And I'm showing you the 2 winners of the Nobel Prize for Medicine. Only the second prize awarded for vaccination research. This was, of course, COVID, and the first was to Max Thieler in 1951 for the yellow fever vaccine work. So I'll end this section by saying that bronchiectasis remains an enigma. Some risk factors and disease associations are described, but the pathogenesis is not well understood. The current prevention and treatment often focuses on late events where there's airway dilation and destruction. We should all work to recognize it early and consider all available modalities for prevention and treatment. And remember, many of the underlying conditions require chronic and multidisciplinary management. We certainly need more basic and clinical science to guide us. I'll move on now to the second part of my talk, which is an introduction to pulmonary non-tuberculous mycobacterial infection, also called NTM, including nodular bronchiectasis. The learning goals for this section are to recognize the epidemiology, risk factors, and clinical features of pulmonary NTM, abbreviated as shown. And we'll use the most common NTM, Mycobacterium avium complex, or MAC, as a model, which is mainly what the guidelines do. To integrate this information into the treatment recommended by the guidelines and to consider preventive strategies. So here's our first patient, a 60-year-old male with a past medical history of well-controlled HIV. He also is a former smoker with COPD and has symptoms consistent with GERD. He has no high-risk epidemiology for TB, and testing for latent TB is negative. He's well vaccinated. He presents to you with a 6-week illness characterized by initial rhinorrhea, sore throat, and dried cough, but persistent and increased wheezing and dyspnea. His evaluation for respiratory viruses is negative, and his sputum shows normal respiratory flora. His chest X-ray is without infiltrates. He's treated with a course of levofloxacin without improvement. And here's his chest CT 6 or 8 weeks later, and this shows tree and bud opacities as small airways disease, as well as some bronchial thickening. There are also multiple new peribronchial nodules. So the person seeing him sends induced sputa, and 2 of 3 are smear positive for a small number of AFB, but all 3 grow MAC. So I'm going to ask you what you would do in this circumstance. The first choice is begin 3 drugs for treatment of pulmonary MAC. The second is begin 4 drugs. Third is to get a lung biopsy, maybe because he has HIV and you're worried about other possibilities. The fourth is an infectious disease consult, but don't do that quite yet. And the fifth is other. So take a minute to think about this. And I'll tell you what we did, which is other. And that is based on clinical experience and these guidelines for NTM lung disease, which were updated in 2020. They focus on the non-CF population and on the most common NTM pathogens. including MAC, M. kansasii, rapid growers, and at least one slow grower. The criteria for diagnosis include clinical, radiographic, and microbiologic. And I've put compatible signs and symptoms in quotes because, as you can see, these are not specific. And reasonable exclusion of other diseases is also depends on how hard you want to look. Radiographically, you want to see nodular or rarely cavitary infiltrates. And the CT often shows multifocal bronchiectasis. Because of colonization without infection, they ask you for at least 2 positive cultures of expectorated sputum, or 1 positive lavage, or 1 biopsy with organisms seen, a positive culture, or compatible histopathology. Now, unfortunately, these are not validated guidelines. Why don't we just treat everyone? Why do we worry about whether this represents disease or not? Well, here's a table comparing tuberculosis to MAC. And as you can see, TB needs to be immediately treated for a variety of reasons, including its person-to-person transmission. MAC is in the environment, and you won't infect someone if you have it for a while. TB is very virulent and can cause lung destruction or even death if untreated. And MAC is relatively avirulent. The potency of TB treatment is excellent, and the potency of MAC treatment is only fair. TB treatment is relatively well tolerated, and MAC therapy is less well tolerated. Short course regimens for TB are as little as 6 months, with shorter regimens under investigation. For MAC, we're usually talking at least 12 months. The cure rate for TB is over 95% with current regimens. For MAC, it's reported to be 30 to 80%, and 30% is the intent to treat analysis, and not 80% is as treated, which allows changes in drugs for intolerance. So this is not something you wish on anyone without certainty. So the guidelines, the good thing about the guidelines is it is consensus by experts reviewing the best available data. But the cons, of course, are the best available data are very limited, and there are very few clinical trials. These are mostly cohort data, and none of the trials are randomized. The studies often lack natural history and long-term follow-up. They're not validated guidelines like the Duke criteria and endocarditis. They are biased towards the most common NTMs, and they're also biased towards multibacillary disease, meaning detection of organisms, versus paucibacillary or low organism load, high inflammatory disease. So clinical judgment is paramount in using these guidelines. My impression was that this syndrome was most consistent with viral respiratory tract infection with post-viral reactive airways. And given his CD4 of 420, I wasn't worried about disseminated MAC in this patient. His symptoms gradually improved over weeks, and the CT findings resolved 4 weeks after the time of this assessment. His follow-up sputa showed complete clearance of the MAC. And so remember, meeting guidelines criteria, particularly transiently, doesn't always indicate attributable disease. So what's MAC disease, and does this patient have it? Soon after the identification of the tubercle bacillus, NTMs were identified, and we now prefer that term to MOTT, or atypical mycobacteria. There was widespread recognition of human disease starting in the 1950s. The early Runyon classification, which many of us learned in medical school, was based on colony and growth characteristics, but Lowenstein-Jensen slants are no longer used, and the much more useful classification is propensity to cause different syndromes and the antibiotic susceptibility of the organisms. Here's a schematic of common species associated with different syndromes. Pulmonary disease, most often MAC, M. kansasii, and M. abscessus, with others less common and sometimes regional. Lymphadenitis is also most commonly MAC, but particularly in children, scrofulation. Cutaneous disease and adjacent structures such as bursae, tendons, joints, and bones are often merinum based on exposure, or two of the rapid growers, coloniae or abscessus, also fortuitum and M. ulcerans or Baruli ulcer in the right epidemiologic setting. For disseminated disease, we worry most about MAC, Kansasii, and then the rapid growers. In AIDS patients or other deeply immunocompromised, also Genovese. Most of these organisms have reservoirs in water and soil, for example, MAC, Marinum, Xenopi, Kansasii, and what are called water and soil bioaerosols from both the natural and built environments, so water supply included, contain NTM. They are enriched in very warm and humid environments, high water pressure, and also conditions of climactic and other environmental disruption. You've already heard from Dr. LaRocque about how big an impact this is having in the ID world. Some are colonizers or pathogens of poultry, citizen birds, swine, etc. And limited studies comparing species isolates do not suggest this is a frequent source for human disease. There's very limited evidence for human-to-human transmission, and that there are reports in the CF setting of this. And US and worldwide prevalence are increasing. First descriptions of pulmonary MAC were so-called fibrocavitary disease. This was often elderly men who had tobacco use or alcohol use, underlying chronic lung disease. It was upper lobe predominant, and it could be cavitary disease mimicking TB or exist in a pre-existing TB cavity. And we're calling this his because there was a male predominance. The new MAC, really described by a pulmonary group in Pennsylvania now decades ago, favors middle-aged females who are non-smokers, often no underlying structural lung disease, a right middle lobe and lingular predominance, and often a fibronodular pattern, and we'll call that hers. So what are risk factors for pulmonary NTM infections? Well, this is from clinical series that show a relative risk that's greatly increased in patients with bronchiectasis. And you can see there is a chicken and egg problem here, but it's clear that some people who've never had an NTM get it in the setting of bronchiectasis. Being very thin or protein calorie malnutrition. I'm going to come back to thoracic skeletal abnormalities, GE reflux, we've talked about a little, COPD, lung cancer, and depending on the type of immunomodulatory treatment, the risk can go from about 2 to 3-fold, for example, inhaled steroids, to so-called infinite relative risk with some of the immunomodulators such as TNF inhibitors. There is probably a heritable genetic risk, but this hasn't been well characterized. Environmental factors include peat-rich soil exposure. Indoor swimming pool use is associated. Proportion of your environment as surface water, and mean daily potential evapotranspiration, which is from water, soil, and plants. Let's get back to thoracic anatomy, which was well described by various groups. And what you see here is a study of 63 patients. 95% of these were female. And as you see below, compared to the rate in the general population on the right here, which is 1 or 2%, a large number of these women had scoliosis, pectus excavatum, and mitral valve prolapse. What this suggests is there are features of the thoracic cage which might predispose you to infection, and in those patients, our antennae should be tuned to NTM infections. There is a large spectrum of disease in pulmonary MAC, and I've diagrammed it here. You can be colonized without any disease. You can develop hypersensitivity pneumonitis, the syndrome of wheezing, cough, fever, and infiltrates after exposure, which typically resolves with steroids and discontinuing exposure. The spectrum of infection to clinical disease includes a coin lesion. You'll be called because a resected lesion contains MAC. In that case, generally, if it doesn't grow in the airways, treatment may not be required, just surveillance. Fibronodular, which we're going to talk about more. Fibrocavitary, we've already mentioned, but consolidation that can resemble different forms of bacterial pneumonia as well. So be alert to this. Here's a 64-year-old female who's a former smoker who's been treated for Legionella pneumonia. But 4 months later, she still has residual symptoms and a chest X-ray and CT with persistent lingular streaky opacity. She's thin. She's not producing sputum, but you induce sputums, and all the smears are negative, but 2 of 3 grow MAC. So please think about what you would recommend. Would you start 2 drugs? Would you start 3 drugs? Would you start 4 drugs? Or no antimicrobials yet? I think you're getting the drift of the way I think about this, and my answer would have been D, or no antimicrobials yet. So these are the questions we should ask ourselves when we're deciding whether to initiate treatment for pulmonary MAC. Does this patient meet criteria for diagnosis? Even if so, are there feasible additional or alternative diagnoses? Is the infection causing significant pulmonary disease? How rapidly is this particular patient's form of disease likely to progress without immediate treatment? Underdiagnosis may lead to disease progression, but overdiagnosis may lead to drug toxicity and resistance. Is the patient at high risk for disseminated MAC? Patients requiring early treatment are rapid progression clinically or radiographically, and that includes cavitation. Be careful that it's not saccular bronchiectasis. The profoundly immunocompromised patients we all see. And in these patients, treatment is to prevent dissemination as well as end organ disease. But they are the minority of patients. Factors favoring a period of observation or reevaluation include evidence of an acute infection that improves. So, for example, an acute viral infection diagnosed or presumed. And do symptoms improve with treatment for other conditions such as GERD, asthma, COPD? And if so, do the cultures clear when the patient improves, which I've seen many times. So patient 4 gave a good history for GERD. Her pulmonary function test showed moderate COPD. She was placed on treatment for both of these, and she had a rapid and marked improvement in her cough. She did progress to needing treatment, and before you initiate treatment, we do counsel patients and manage expectations, as you see here. The first is the natural history of this disease can vary. It is a relapsing or remitting or even chronic disease where the goals of therapy are really more remission rather than cure. There's a potential for relapse or reinfection, as we'll discuss. We focus on symptoms and not imaging because some imaging findings don't change with treatment. We describe the side effects and strategies to mitigate them, and individualized treatment to the host, the organism burden, and the clinical and microbiologic response of that patient. Here are some preferred initial regimens in pulmonary MAC. This afternoon, Dr. Hurtado will discuss some advanced treatment strategies, both for MAC retreatment, but also for other NTMs. For daily treatment, we stagger the start by days to ensure patients have subjective tolerance. Azithromycin is the preferred macrolide. Rifampin, or less commonly rifabutin, are the rifamycins. And ethambutol at 15 mg per kg per day in initial regimens. There are some patients in whom 3 times a week therapy can be considered. This is better tolerated and may be equivalent in small studies. There is concern about resistance, particularly if the patient has multibacillary or smear-positive disease. It is recommended for people who have nodular bronchiectatic disease, or patients who can't tolerate daily treatment, or patients who don't require aggressive treatment. If the patient has cavitary or multibacillary disease, so smear-positive disease, we often start with a fourth drug and in some cases a fifth drug, depending on the drug susceptibility. And we consider surgery, as Dr. Hurtado will describe. One question we're faced with is in people with recurrent infection, which can be up to 30% of these patients, can environmental or behavioral modification prevent NTM? And infection recurs in up to 30%, and up to 50% of these are new strains. These are identical to environmental sources. So if you move to a cold, dry climate with this help, if you avoid pools, hot tubs, and warm water lakes where these organisms are aerosolized, and I have to admit, in some patients with recurrent infection, I have recommended this. Should we prefer baths to showers because of fewer aerosols? And there are data that show that some types of shower heads and bathtub inlets are more likely to contain NTMs, and should we advise that those be modified? I think there's very little evidence for these last two, but it is a compelling association. What about telling people to cough more? Well, many of you have heard the eponym Lady Windermere syndrome, which is isolated lingular or middle lobe pattern seen in these women. And is this because, as in Oscar Wilde's play, they're too polite to cough? Well, this was really based on a study of 6 patients, and no reports of pulmonary disease either caused or influenced by the mechanism of voluntary suppression of cough exist. So it's a nice story, but there's no evidence for it. So I'll end by saying NTM may be colonizers or may cause a spectrum of lung disease. It's often recurrent or chronic. The most common current presentation is fibronodular bronchiectasis in middle-aged women. There are no validated guidelines for diagnosis or treatment, so you must use your clinical judgment in addition to guidelines and individualize it to the host and the form of disease. Remember to use your internal medicine skills and diagnose, prevent, and treat coexisting conditions, and to observe the natural history. In some cases, the picture remains unclear, and we do then ask for a tissue biopsy, and we certainly need more studies of pathogenesis, prevention, and treatment. I'm going to end now with pneumonia, and my goals here really are to reason through cases that highlight the clinical, radiographic, and microbiologic features in the diagnosis and management of pneumonia. In patients with severe or complicated pneumonia, particularly in the setting of medical illness or immunocompromise, making an etiologic diagnosis can help guide optimal treatment, preventive strategies, and infection control measures in the hospital and out of the hospital. It follows that a more nuanced understanding of the correlation between these things can help make an etiologic diagnosis, and that will really be the focus of my talk. No infection has only one radiographic pattern, and of course, anything I say may differ in early and late disease. I'm going to start by saying what is atypical pneumonia, and this is a bad term. It was coined in the 1930s to contrast with classic strep pneumoniae lobar pneumonia. Since then, it's been used variously to mean an atypical presentation, so without purulent sputum, or consolidation, or with a milder clinical course. More recently, it's been used to mean a non-bacterial etiology with some signs and symptoms and X-ray findings of pneumonia, but no pathogens isolated on routine cultures. This can include viral, mycoplasma, chlamydia, and Legionella, and also some zoonoses like tularemia and Q fever. It follows from the number of organisms I've mentioned that the radiographic patterns of atypical pneumonia can differ. Excuse me. Patient 5 is a 42-year-old male former smoker who presents in June, and that's important. He has rhinorrhea, sore throat, and a low-grade fever. He now has inspiratory and expiratory wheezes, worse with deep breathing and speaking, and fever and increased dry cough. He doesn't have post-tussive emesis or a whoop, and his vaccines are up to date. Here's a chest x-ray, and you can see it's very white, and there are innumerable little white dots here in the interstitium. So this brings me to my framework for the radiology of pneumonia, which is based on the secondary pulmonary lobule, shown here. So here on the right and on the left in this diagram is the bronchovascular bundle. It contains the bronchiole in green, the pulmonary artery, and the central lymphatics as well. And remember, out at the periphery, the pulmonary artery will never be dilated enough to see. So if you're seeing something, it means you're seeing a bronchiole. The pulmonary arteries are 1 millimeter, and the bronchioles normally are 0.15 millimeters at the periphery. So that patient I presented has worsening symptoms with cough without sputum, but dyspnea as well as shortness of breath at rest. And here's the first cut of the chest CT, and what you see here is these innumerable small foci, and these are small airways. But in addition, he now has these ground glass opacities and a couple of areas of early consolidation that are associated. So is your diagnosis bronchiolitis and pneumonia due to RSV, bronchiolitis and pneumonia due to flu A, bronchiolitis and pneumonia due to human parainfluenza 3, or flu A with bacterial infection with Staph aureus? So please take a second to think about this. And I hope many of you noted the seasonal clue here and said number C, which is the parainfluenza. So bronchiolitis is very common in adults, although often medically attended in children. The most common etiologies are RSV, parainfluenza, adenovirus, and metapneumovirus. Note that COVID rarely causes bronchiolitis. Flu is a common cause of viral pneumonia, but is less likely to be associated with bronchiolitis alone. There are 4 types of parainfluenza virus, but PIV3 infections often occur in the spring and early summer months, such as now. These are more likely to be associated with pneumonia than the other types, and are a cause of severe infections in immunocompromised hosts. And this is, in fact, what our patient had. So respiratory viral pneumonia, when it occurs, is often associated with bronchiolitis or bronchitis. And on the left-hand side, you see our patient, and this is bronchiolitis. And there's invasion of the virus through the wall of the distal bronchiole with spread to adjacent alveoli, which is called a peribronchiolar pattern. Contrast this to flu A, where the invasion really occurs in the wall of the more central bronchus with spread to adjacent lobules, or a so-called peribronchial pattern. So why does it matter if we know that someone who's ill has viral community-acquired pneumonia, which is up to 25 to 30% of pneumonia in adults? It has infection control implications in the hospital, either contact or droplet precautions. There are limited antivirals, but certainly they exist for flu and in some settings for RSV. Antibacterial, both selection and deferral, are impacted by recognizing that someone has viral pneumonia. Clinicians can be aided in this setting by procalcitonin, and it may be a useful adjunct if someone is clinically stable without comorbidities, has the typical clinical and imaging features of viral pneumonia, a very low procalcitonin. That may help you with the decision to defer antibiotics and observe closely. In this study cited here, the procalcitonin is about 70% accurate in distinguishing bacterial from viral pneumonia, although notice that so-called atypical organisms such as Mycoplasma or chlamydia may also have a low procalcitonin. Not all bronchiolitis is viral, and if you see a patient who has cough with sputum production and fever that persists, it may be bacterial bronchiolitis. Here's an example of Staph aureus on the left, and on the right, Haemophilus influenza in a non-vaccinated host, and these both improved with antibiotics. Our next patient is a 50-year-old healthy female school teacher who presents in February with sore throat, myalgias, fever, chills, and nausea, followed by shortness of breath. She's febrile, tachycardic, and tachypnic, with a few inspiratory crackles in the area where you see this ground glass opacity and early consolidation on a chest X-ray. So what do you recommend for antimicrobials for this patient? Oseltamivir? Oseltamivir, or one of the recommended antibiotics for community-acquired pneumonia, oseltamivir and amoxicillin clavulanate, or oseltamivir and levofloxacin. I'm hoping that many of you picked C, oseltamivir and amoxiclav. And the reason is, in adults with flu, treatment of CAP should include antibacterial therapy. And this is because bacterial superinfection is more common with flu than other respiratory viruses, and it can be rapidly progressive and lethal. And delays in diagnosis and treatment are associated with poorer outcomes. Why should you include Staph aureus? And that's because the etiology of community-acquired pneumonia without flu, Staph aureus is 5th or 6th on the list. But after the flu, although pneumococcus remains the most common, Staph aureus moves up to number 2. And MSSA is still more common than community-acquired MRSA in most settings. But in your setting, it might not be. And most ID clinicians would therefore include at least MSSA in outpatient treatment, although there's not specific evidence for this. Include MRSA if they have a history of colonization, if they have risk factors or concern for severe disease. Remember that a nasal swab has a 70 to 90% negative predictive value for respiratory MRSA, though it's rarely available in the outpatient setting. And in patients with severe disease, we would not rely on this negative predictive value. So our patient was begun on levofloxacin as an outpatient. She's admitted 2 days later with worsening shortness of breath and shock, and her sputum and blood cultures are positive. And here you can see the marked worsening in her chest X-ray. Would you call this lobar pneumonia or bronchopneumonia? And while these are old-fashioned terms, they do have descriptive power, and I'm going to show you why. So Staph aureus is associated with a peribronchial, so-called peribronchovascular, or bronchopneumonia. And on the right here, you see the bronchovascular bundle. And I call this the lollipop sign, which is staph invading through the wall of the bronchus with spread to adjacent lobules. These may coalesce, but initially they may look like these peribronchovascular nodules. And here you see coalescence, although not in a lobar pattern. So when you see this, think of staph, and obviously with flu, think of staph. Now, Staph aureus bronchopneumonia and Staph aureus septic emboli can be confused on chest imaging, and both can be associated with positive blood cultures, as in our patient, and both can have a peribronchovascular pattern. But there are some subtle differences, and on the left here you can see, because the organisms are deposited on epithelium of the bronchi, there's a lot of bronchial inflammation, but in addition, there's a great deal of inflammation around the bronchus that then spreads into contiguous lobules. On the right, you see a CT of Staph aureus bacteremia, and here the organisms invade through the distal pulmonary artery. It's usually more peripheral, usually multiple, and there's not typically extensive bronchial inflammation. These patterns can be overlapping. Every year, we see 1 or 2 patients who have a history called viral bronchiolitis or pneumonia. And you can see how if you saw the top of this CT scan, you might read this as tree and bud opacities. However, it wasn't viral or bacterial, it was lymphangitic carcinomatosis. And both the persistent symptoms without a diagnosis and the chest CT pattern were suggestive. While central lymphatics are present here in yellow in the bronchovascular bundle and may resemble bronchiolitis or pneumonia, remember that peripheral lymphatics are present along the interlobular septae and the pleura, and that should not be seen in bronchiolitis or pneumonia. And here you can see many places where it is seen. So that is a tip-off. I'm going to end with patient 7, who's a 60-year-old male with COPD and alcohol use disorder. He presents with prominent GI symptoms and pneumonia. And you can see here that his transaminases are elevated. He has acute kidney injury. He has an elevated CPK and a sputum that has inflammation, but no organisms on culture. And this is an example of lobar pneumonia, and the pathogenesis here is that the organisms travel to the alveolar spaces and create an inflammatory exudate. They spread through intraalveolar pores, so-called pores of Kohn, and create consolidation abutting the pleura. This may involve several contiguous segments, or as seen here, a lobe. You see the airspace disease and the consolidation here. So what do you think this patient has? Is it pneumococcus? Is it Legionella, Mycoplasma, or Klebsiella? Well, it turns out that all of these can cause lobar pneumonia, although not solely lobar pattern. But there are many features here favoring Legionella, so-called gastroenteritis with pneumonia, neurologic findings, and the lab abnormalities our patient had. 70 to 80% of US cases are Pneumophila type 1. And if you want to isolate this from culture, which isn't routinely done, you have to use buffered charcoal yeast extract. The implications for diagnosis are that community cases may be sporadic or represent outbreaks, and water tanks and reservoirs, cooling towers, whirlpools, decorative fountains, or even grocery store mist can be reservoirs. This is a reportable disease, and our patient had probably gotten this in the pool and steam room at the YMCA, which was then disinfected. In healthcare associated, we pay a lot of attention to the water supply in hospitals. The prognosis here is not as good as for other forms of bacterial pneumonia, particularly in patients with severe disease or these underlying conditions. And even with early appropriate treatment, the mortality may be high. If you don't consider it, it's much higher. In early retrospective studies, low dose or short course macrolides were associated with poorer outcomes. There are no randomized controlled trials comparing quinolones and macrolides, although in the case series, there's more rapid defervescence, fewer complications, and shorter hospital stays with quinolones. The options for treatment include, probably in this order, a quinolone or azithromycin. And remember, with macrolides, you can see ototoxicity with high doses. This does require longer treatment than other forms of community-acquired pneumonia, 7 to 14 days in a normal host, and even longer in compromised hosts or more complicated disease. Our patient unfortunately progresses and develops complications of cavitation and empyema. So in this case, would you recommend dual therapy, addition of azithromycin or rifampin? There are small series in which this is done. There are obviously toxicities and interactions to consider. However, there is really no proven benefit to doing this and maybe toxicity. So we don't do this in our patients. I'm going to conclude by saying that integration of some of the radiographic and clinical features we've discussed may result in benefit for treatment and prevention, timely infection control, and important public health interventions. Thank you. Please put your questions in the chat. And there's some supplemental slides that follow.